The topic today is intracerebral hemorrhage, and in both, there are MS people here too, right? Yeah, okay. In both units, largely because of our stroke program, we also see a lot of patients with spontaneous intracerebral hemorrhages. So what we're talking about here is a form of air quotes stroke, and that stroke is really a layperson's term used to denote a sudden neurological deficit. So what we're talking about is spontaneous intracerebral hemorrhage, which is the second most common form of stroke behind ischemic stroke from like thromboembolic disease. So the strokes that Devlin and company treat, you know, with their fancy catheters and all that, lysing clots, that's the most common form of stroke. This is the second most common form. Unlike a classic thromboembolic event, I'm excluding so-called like crescendo TIAs and such. For the most part, if a patient has an ischemic stroke, they have this deficit right at the onset, and that's kind of it. With intracerebral hemorrhage, there's often a progressive symptom onset, often accompanied by headache, nausea, vomiting, alterations in level of consciousness. The initial study of choice, you're used to seeing them done, is CT without contrast, and we'll talk about other studies to get. An important concept is that there's a direct correlation between the volume of a hemorrhage and a patient's outcome, both their morbidity and their mortality risk. We get angiography and MRI, as you know, in some patients, and again, I'll touch on that in a little bit. The treatment, there's some controversy in the treatment in terms of which patients to treat medically and which patients to treat surgically. And again, we'll touch on that. Surgery, for the most part, we reserve for, it's an individualized decision, but selected patients with superficial or lobar hemorrhages, so in the frontal, parietal, occipital, temporal lobes, or certain cases of cerebellar hemorrhage. Moving on to the epidemiology, those figures speak for themselves, but that incidence of 12 to 15 cases per 100,000 population per year, that's roughly twice as common as subarachnoid hemorrhage. Risk factors for intracerebral hemorrhage are being over 55, more common in males, it's more common in African Americans. A prior CVA increases someone's risk 23-fold. Ethanol consumption, kind of a bummer there for some of us, but there's both a correlation acutely between if someone consumes ethanol and the incidence or likelihood of having a intracerebral hemorrhage acutely afterwards, as well as chronically. If someone chronically consumes alcohol, if someone consumes more than 3 drinks a day, it increases the risk of an intracerebral hemorrhage 7 times. Hypertension is obviously a risk factor. I'll talk a little bit about that. People debate about the role of hypertension in intracerebral hemorrhage. Certainly with probably around 2/3 of basal ganglia hemorrhages, many of the lobar hemorrhages, many of the cerebellar and pontine hemorrhages are related to hypertension and so-called small vessel disease. Sometimes you get into a chicken and egg thing in that, and you guys have all seen this, where you have a patient with a big hematoma, so their blood pressure goes up to perfuse their brain, and so you don't know, were they hypertensive, especially if they didn't see an internist regularly. Were they hypertensive beforehand, or is this just like an epiphenomenon? They're hypertensive because they've got this big clot in their brain. The locations, most frequently, they're in the basal ganglia. Everyone remembers the basal ganglia, right? So caudate, putamen, globus pallidus, all those things. The thalamus and pons are close to each other. For those of you in neuro, we had a patient not very recently with a thalamic and brainstem hemorrhage. Cerebellar, cerebral white matter, both about 10%, and less frequently primary hemorrhages in the brainstem. Lobar hemorrhages, so now I'm talking about, again, hemorrhages that are in either the frontal, parietal, occipital, or temporal lobes. They're more commonly related to a structural abnormality. So they could occur from small vessel disease and hypertension, but they should prompt you to think about other things like neoplasm, AVM, sometimes they can be aneurysmal, coagulopathies, an ischemic stroke that's converted into a hemorrhagic stroke. We have a girl now in neuro, some of you may have seen, who has an AVM and has, at least in part, a lobar hemorrhages. Part of what complicates things is that you can have a lobar, a deep hemorrhage that extends to one of the lobes of the brain, or vice versa, a lobar hemorrhage that extends deeper in the brain. It can be hard to tell which which area it came from. Lobar hemorrhages are more common in ethanol users. In general, they have a better outcome than some of the deep-seated hemorrhages, which conceptually make sense. CAA is cerebral amyloid angiopathy, which I'll talk about briefly. They can also occur in the wake of trauma, as I mentioned. In addition, they can be idiopathic. An important concept in terms of having a hemiparesis and recovery is the internal capsule. So the internal capsule, you'll recall, is the fiber tract or white matter tract that extends from the cortex down through the spinal cord, forms the corticospinal tract. So if the internal capsule is affected, and it also confers sensory fibers going up to sensory cortex. So if the internal capsule function is deranged, if it's just from the clot pushing on it, for example, lobar hemorrhage extending deep, then a patient may recover their hemiparesis. Conversely, if someone has a deep thalamic hemorrhage and it extends into the internal capsule, oftentimes it destroys part of the internal capsule and they may not recover that function. So it can be important whether the clot, in general terms, is medial or lateral to the internal capsule. I'm moving on to the second page now, and at the top is CAA. Again, that's cerebral amyloid angiopathy. It's more common in elderly patients. These hemorrhages are classically lobar, and they're classically superficial. On CT, you see them come right to the surface of the brain. And some of these folks, many of them don't really do well if you operate on them. They can recur, and they can also recur after you take them out, but they can also have recurrent separate events of intracerebral hemorrhage, because of course the amyloid angiopathy affects their small vessels diffusely in their brain and basically weakens them. Another entity that we'll sometimes see presenting as a spontaneous hemorrhage are hemorrhagic brain tumors. That occurs more commonly in malignant than benign tumors, and some of the more frequent players there, as noted, are glioblastoma, lymphoma, metastatic tumors, especially melanomas, notorious to bleed, as is choriocarcinoma and renal cell carcinoma. Bronchogenic carcinoma can bleed. Part of the reason it's on there, I think, is just because it's a relatively frequent tumor. So there are just so many of them that even though their propensity per tumor may be lower to bleed than, say, a melanoma, there are probably more of them. And then less frequently, benign tumors like meningiomas occasionally can hemorrhage, and pituitary adenomas can hemorrhage. Anyone remember what that's called? A big macroadenoma hemorrhages? Pituitary apoplexy. Has anyone seen that? No. Okay, that's apoplexy. So moving on to some of just how these things can present clinically. Putamental hemorrhages. So the putamen is part of the globus pallidus. They tend to have a smooth, gradual deterioration. They often do not have a headache, those patients. They have a contralateral hemiparesis, and they can progress. If the hemorrhage enlarges and starts to affect their brainstem, then they can have a depressed level of consciousness and become comatose and so forth. Thalamic hemorrhages classically present with a contralateral sensory loss. They may have a hemiparesis as well, and they can extend into the brainstem. And if they do that, then frequently what happens is you'll have a depressed level of consciousness. Everyone remember the reticular activating system, right? So brainstem function suppressed, level of consciousness tends to be depressed, and they can have various cranial neuropathies. In particular, if thalamic hemorrhages extend to the upper part of the brainstem, you can see various abnormalities with eye movements. Cerebellar hemorrhages, if they're big enough, tend to present with symptoms of elevated intracranial pressure. So headache, nausea, vomiting, hypertension, bradycardia. If they directly compress the brainstem, then again you can see a depressed level of consciousness and various cranial neuropathies, like bulbar dysfunction, so someone may not be able to protect their airway, may fail a swallowing study, things of that nature. With the lobar hemorrhages, of course, it depends on their location. So a classic frontal lobar hemorrhage can present with a headache, and if it's far enough back in the frontal lobe near the motor strip, it can give a patient a hemiparesis. Parietal hemorrhages can present with contralateral sensory dysfunction and potentially hemiparesis if they're far enough anterior. Occipital hemorrhages can present with ocular pain and a field cut. And then temporal hemorrhages, if they're in the dominant hemisphere or dominant temporal lobe, they can present with various forms of aphasia. It is frequent for these hemorrhages to progress. Roughly a third of them will progress within the first few hours. So if you see a patient that deteriorates in a delayed fashion, the things to think about are, have they rebled, or has their hemorrhage extended, particularly within about the first 6 hours. After that it becomes less frequent that a hemorrhage is going to extend. So rebleeding, are they experiencing edema? And no two of these are exactly alike, but in general stroke edema peaks within about the first to third day after the event. Have they developed hydrocephalus? That can occur particularly with thalamic hemorrhages, with hemorrhages with intraventricular extension, or with cerebellar hemorrhages, and we'll talk a little bit about that. Or are they having a seizure? Basically, that would be with lobar hemorrhages. Subcortical hemorrhages, by and large, won't cause seizures. Everyone still with me on the handout? So we just finished page 2. You made it. That next page is an ICH score, and it was developed by someone named Hemphill and others, and it's pretty self-explanatory, but we'll briefly run through it. So there are a few features to it. GCS score, obviously the lower the okay, so higher, I should mention, the higher someone's ICH score, the worse their prognosis, the higher their acute mortality. So the lower the GCS score, the higher their ICH score. So again, it's self-explanatory, but 3 to 4, they get 2 points, 5 to 12, they get 1 point, and 13 to 15, they get 0 points. Age, being over 80, their prognosis is worse. Under 80, they get a 0. Location, infratentorial, so like posterior fossa, brainstem, they get a point. Supratentorial, like a lobar hemorrhage, they get 0. And then ICH volume, as we discussed. So over 30 cc's or under 30 cc's. Again, self-explanatory. So the way to measure a hemorrhage, does everyone know how to measure a hemorrhage on a CT scan? No? Okay. I'll probably have to show you all in the unit. But basically, you measure, there are different ways of doing it, but an easy way is to just take the biggest, the slice, the CT slice where the hemorrhage is biggest, and measure it AP mediolaterally. And then what you do is look at the slice thickness on the CAT scan. Usually it's about 5 millimeters. Some formats it's 3 millimeters in the posterior fossa and then goes to 5. So you count how many slices you see the hemorrhage on. Are y'all following me? So say a hemorrhage is 4 by 5 centimeters, and then say it's a 5 millimeter slice thickness, so it's on, say, 6 slices, so that's 3 centimeters. So geometry's painful this early, isn't it? So it'd be 4 times 5 times 3, so it'd be 20 times 3, so it'd be a 60 cc clot. Does that make sense? Now some people say, well, most clots really are ellipsoidal, so you can divide that by 2, but we'll keep it simple for now. And then if they have intraventricular extension, that confers a worse prognosis, so they get a point if they have intraventricular extension. And then you can see the mortality is again, self-explanatory. So this was based on a series. As you can see, no patient in the study had a score of 6, but they just anticipated 100% mortality, since patients with a score of 5 had 100% mortality. So now we're moving on to the 4th and final page. Management. All you need to know about management in 1 page. Obviously, most all these patients with a significant hemorrhage we admit to the ICU. And a key thing there is blood pressure control. Now, there's some controversy there. People debate about how much to reduce someone's blood pressure. And one problem you run into, especially in our population of patients at times, is that we frequently are treating someone, as I tongue-in-cheek said earlier, but someone who hasn't been to the internist once a year. So they may say, like, Grandpa, he's healthy, but you look at the guy and he doesn't look healthy, or his blood pressure's so high you think he probably had undiagnosed and therefore untreated hypertension for 20, 30 years. It doesn't mean he didn't have it, just like someone who's a type 2 diabetic who never gets their blood sugar checked, never gets diagnosed. They were diabetic, but they just don't say they're diabetic. So anyway, one thing you can do is, if you know where their pressure used to run, you can try and make your target where their pressure was when they were being treated. or you can reduce their MAP by 20%. A general target is 140/90. Sometimes I don't get quite as aggressive with the systolic if I don't know where someone's been running, because again, you're walking a balance between perfusing the brain and in theory keeping the hemorrhage, lessening the likelihood the hemorrhage will extend acutely. And then, of course, we employ routine supportive measures. Intubation in general, if someone's GCS is 8 or less, you worry about airway protection. Obviously, we want to maintain things like euglycemia, normothermia, and so forth. AEDs are anti-epileptic drugs, so someone with a lobar hemorrhage or someone who we know is seized, Keppra is a good choice there. And then hemostatic issues. Obviously, we check all their coags and then take a history about have they used aspirin and Plavix. In terms of treating intracranial hypertension, everyone's familiar with that. We employ mannitol, sometimes Lasix. If they have a depressed level of consciousness and require intubation in general, we like a monitor. Nova 7 was a drug that showed promise in some of the initial trials, but in subsequent trials it has not really shown an outcome difference. I just mentioned it there for completeness sake. And then there was a STITCH study. It was an international study for surgery for selected intracerebral hemorrhages. It had just over 1,000 patients enrolled. There are multiple flaws with the study, including a selection bias. But basically, it did not show any clear difference between surgical treatment and medical treatment. The one subpopulation of patients with superficial or lobar hemorrhages, there could be a role for surgery. The other thing that needs to be looked into with surgery is with the stereotactic techniques we have, so to be able to localize things precisely in three-dimensional space, employing a combination of like a minimally invasive stereotactic technique with something like TPA for some of the deeper hemorrhages, and that's being looked at. Moving on now to the ICH management part. As I said earlier, these are individualized decisions. There's no cookie cutter like that everyone agrees on. Factors that favor not operating on someone are as follows. A minimally symptomatic lesion, which intuitively makes sense. If grandpa comes in and he has this tiny 1 centimeter hemorrhage and he's awake and alert, how are you going to make him better with an operation? So minimally symptomatic lesions. The other side of the scale, little chance of a good outcome. So someone comes in, they're 85, they're on Coumadin, and they have this massive brainstem hemorrhage. Obviously, we're not going to operate on them. But as all of you are aware, oftentimes it gets grayer than that. It's not that clear cut. Some of these things kind of go hand in hand. So high ICH score, a massive hemorrhage, hemorrhage in eloquent brain. So hemorrhage in, like in the brainstem as opposed to a hemorrhage in so-called silent brain like the non-dominant frontal lobe. Poor neurological status. If someone's profoundly comatose at the get-go, their prognosis, as we discussed with the ICH score, is worse in age over 75. And then factors that favor at least considering surgery are moderate volume of hematoma. So again, someone with a massive hematoma we're less likely to operate on for the reasons we discussed, and someone with a small hematoma we're unlikely to operate on for the reasons we discussed. If someone has a moderate volume hematoma, they're getting into trouble from mass effect or ICP and or their medical, you started down the road of medical management, but that's failed. Favorable locations, as we discussed, are lobar hemorrhages, hemorrhages in the external capsule, which is superficial, non-dominant hemorrhages, and patients who are younger, especially under age 50. And the last thing that I've listed there are external ventricular drains, just EVD. There are some folks who put TPA into external ventricular drains if a patient has a big volume of intraventricular clot. It will help lyse the clot faster, but it has not yet been shown to make a clear-cut outcome difference, so there's probably more to follow there. Lastly, cerebellar hemorrhages, they always get our attention. We like to know about all of them because, as most of you are aware, those patients can head south very acutely. These are just very general rules of thumb, and again, it's an individualized decision, so I wouldn't say all neurosurgeons agree on this, but in general, someone with a good level of consciousness, so GCS greater than or equal to 14, and a hematoma less than 4 centimeters in diameter, usually will manage non-operatively. If someone has a GCS less than 13 and or hematoma greater than 4 centimeters, we'll have a greater tendency to operate on them. But again, not everyone would agree. In other words, not every neurosurgeon would look and say, oh, that's a 4.5 centimeter hemorrhage, I'm going to operate on it. That's not a universally agreed. It's just a general sort of guideline. The other thing is, if someone has a cerebellar hemorrhage, and in the same vein as we discussed with the other intracerebral hemorrhages, they're elderly, or when they show up they're like a GCS3, then we're probably not going to operate on them. And if they have hydrocephalus, oftentimes they'll require an external ventricular drain. But usually if someone has a cerebellar hemorrhage big enough to give them hydrocephalus and you're going to treat them, you should operate on the cerebellar hemorrhage plus or minus an external ventricular drain, because when you decompress them, oftentimes their hydrocephalus resolves. And that's it. Intracerebral hemorrhage in 28 minutes. Thanks.